My name is Lisa Garber. I'm the program manager for this online MPH, and I work really closely with our students once they're admitted and onboarding to the program and persisting through the program. So I just wanted to take a moment to say hello to all of you. Most of you are somewhere in the funnel in the application process of either pulling together your application materials or awaiting an admission decision. And so I'll be a key resource to you throughout that time. And certainly, if you decide to join the program, we'll be working very closely together. So I want to say hello.
So welcome, everybody. We're going to wait just another minute or two while people kind of make their way in. So one of the things that maybe I'll just start with is a little bit of an introduction for myself. Um, so I am Sharon Kardia. I'm a professor of epidemiology. I'm the director of online programs. And I'm also the Senior Associate Dean of Education for the School of Public Health. I've been at the School of Public Health for about 25 years, and this is sort of one of my favorite programs, and I was one of the key architects, and love teaching online, and love the online students, and we're hoping that today you get a little bit of a taste of what it's like to learn online. And before I go too much further, I'm going to let Reed introduce herself.
Thanks, Dr. Kardia. Hi, everyone. Welcome. My name is Reed Richards. I use she, her pronouns, and I am a current second year MPH student in the Population and Health Sciences program. I'm super excited to be joining you all tonight to kind of, help you see what a regular class looks like and get a feel for what to expect in this program. It's really helpful to find your best fit program, and hopefully that we'll have that opportunity to explore what class looks like tonight and go from there.
Yep. So one of the things, if you're able and willing, would be to even just start by turning your cameras on, and maybe even we could start to have a sense of the breadth and depth of the interest. I really appreciate seeing everybody's faces. One of the things we really highly value at the University of Michigan is the people-to-people connection, and you'll see that kind of over time that what we're kind of best at is that connection with students and faculty working together on big problems. And um, we will, I'm going to say, get a more robust and fun conversation as we start to get to know each other a little bit. You were all given a video and a reading to do, and this comes from my class on population health, which is a lot like public health, but different. And it's this merging of public health's values and strengths with healthcare's values and strengths that really typify kind of this new era of population health that really took hold with the Affordable Care Act, because it was really set aside as a major sort of thought of how we would get ahead of the big and chronic diseases. So in our sort of design of this course, we are taking both of these perspectives as much as we can, because it's the, I'm going to say, best possible outcome for both the degree and for the course if we can get public health and healthcare to be kind of shoulder to shoulder in the U.S. healthcare and public health issues. So hopefully you feel like you got a little bit out of that. I mean, I know a lot of the online students that come into our program already have a wealth of experience. Often they're working in public health. So Reed works at the CDC. We have people working at, the Department of Health in Michigan. We've had it at Ohio, certainly the West and the East Coast. And we've had people that have transitioned, for instance, even inside of the program from, for instance, being an active military to being the community health organizer in Alaska. So this is part of the fun of being together, is that we get the benefit of each one of your own experiences inside of the conversation. And I'm hoping that today we could probably, kind of simulate what it might be like that first day or that first week. Nobody knows each other. We really are just faces on the screen, kind of wondering how much we know and don't know compared to other people. And that in kind of starting with the material as the center, that we start to actually have a conversation. And the online space has become pretty amazing. The pandemic really, I think, made Zoomies out of most of us. And we often will, in a larger class, we'll break up into breakout rooms, maybe, you know, 4, 5, or 6 people that, you have to kind of introduce yourself, and you have to start to get to know what are your backgrounds and what are your strengths. Um, in this population health class, where we're starting with the big question, what is population health? We give a few readings that typically have been, kind of curated because they do a great job of talking both big picture and specifics. And it's that going from big picture to specifics over and over again that kind of stretches our muscles and gets our ability to talk about the field. And I thought that, okay, maybe for this sort of moment, that we might actually start by having a discussion on the paper that I sent out, because diabetes is one of these issues that affects every community in the United States. It has a lot of, I'll call it social determinants of health, but then also there's a lot of things that people do themselves that could actually help to prevent the disease or, for instance, better manage it. And so thinking through the different layers from individual to community to population, from the perspective of prevention or healthcare, is something that most of us can start to think, oh, well, I can see this piece of the puzzle. And so we're gonna work together in a minute on a Google Doc that we can kind of all go in. And inside of that, you can just start, putting in some of your own responses to the questions that we have. And we'll start kind of question by question. And we'll do a technique I like where we just have like a minute and people will like put some things in there. And then we'll have a little bit of a conversation. We'll go to the next question and we just will build basically the puzzle pieces together. This is one of the nice sort of parts of the technology where everybody can chime in, everybody can have access. And I just want to check to see, is there anybody who's having issues getting into the document? It's fine if you're not in, but just even sort of give a try. What do you think are some of the biggest struggles for people who are living with type 2 diabetes? Put yourself in their position. It's one of the best ways for us to start to think about what the public or community needs, is by putting ourselves in their shoes. So already seeing good things like access to medications, that's really key. Certainly with some of the major um, shortages in some of the new medications that's been diverted by people's interest in weight loss. That's been a real, you know, um, I'm going to say eye opener. I don't think we've ever had that kind of competition for diabetes medications before. Another great one I see here is transportation. That certainly is an issue for older people or people that don't have transportation, how are they supposed to get to their doctor's appointments? Um, if you think about some of what you might have seen in the paper, in the chapter, that there are community opportunities or issues, there's healthcare, there could even be issues inside of healthcare, God forbid. But there might be some issues inside of our healthcare system in the US. Um, Another great example, the ability to exercise and get active. Does somebody live or work in a space where it's safe, where it is convenient to actually do exercise? I mean, we have parts of our schools Center for Social Epidemiology and Public Health that really look at urban planning, and they look at the space in which we've created, really kind of harsh conditions for people to actually get out and exercise. Um, these are some great things. Yep, access to the right food and diets. We've a tremendous number of people in the United States that are food insecure, don't really have access to the range of foods that could help somebody manage their diabetes or prevent it. And that can be sometimes hard for um, people within a healthcare system that typically aren't facing that same thing. Physicians or nurses, can't kind of imagine how that could be. And somebody who is living that absolutely sees what a struggle it could be. Um, so these are the kinds of things, if you were to, let's say, keep going inside of here, that we would want to know, how do we solve some of this? How would we do some intervention? And so I want to say, keep going if you have more ideas. But then the other question, which was, what are some of the barriers to getting the health care they need? Costs, absolutely, costs are a major one. And um, I was just reading today that, as we hit the debt ceiling, people are starting to think about shifts in Medicare, the age at which Medicare is, accessible to all. And you could imagine, because diabetes is often increasing with age, that this becomes more and more detrimental to a population as we shift major population programs. So that's another sort of top of mind. I see healthcare bias and health literacy. Absolutely. We know from many different studies that when somebody is given a diagnosis like diabetes or hypertension or some other thing, that often there's a kind of shock moment where they can't really process what's going on. They don't really get the information that they need when they leave to actually navigate the kind of management of their own health conditions. So that health literacy, and I would say support, whether it's support groups from a healthcare system, or just even the access to physicians that would be able to treat patients like them in their kind of, I'll call it, unique social situations. So we've got a lot of potential barriers in the healthcare systems that we have today. And I think there's been some evolution that has been through the population health lens. And I don't know um, if people have, kind of heard of community health workers, but that was a very special kind of way that healthcare systems, thinking through a public health lens, trying to situate people inside of communities that would be of service to especially patients that have chronic diseases, diabetes, hypertension, heart disease, and it can keep going out beyond that, because there's certainly, as we age, things happen. So having community health workers has been a major support for many of the healthcare needs inside of some of the, I'll call it big advances that some hospitals and healthcare systems have tried to make. Hasn't been perfect and it's not been uniform. So it really depends on where you are. Maybe from here, we could start to think about for all of these different barriers and these different kind of struggles that people living with diabetes might have, what could be some of the solutions? So what might you do if you had the Master's of Public Health degree and the position in a local or even state Department of Health to actually start to think about what would you do around the barriers and the issues that you just articulated? Um, and one of the really nice things about what we're doing right now is that for you, there's no restrictions. If you want to come up with something that is expensive and takes a long time, go right ahead. Because of the way in which, if you really think about how creative, human beings can be, it often starts by them going outside of the practical. And then we come back in and see what could be done. And each one of you has a kind of brilliance or genius in this space because you're inside of your own kind of desire to learn. So you've got a spark that is already bringing you here. So now, what else could you lend kind of to the collective need for great ideas? So we've got population education in a more accessible way. Um, Love the population health management platform that drives insights and actions. That's huge. There are some great exemplars out there. Some healthcare systems are doing it really well and some are doing it meh. Um, Love the safe green spaces and active transportation. One of the things that I heard about maybe about 7 or 8 years ago that was a mind blower for me was uh, concierge services for low income people. And I was like, that is brilliant. Oh my gosh. Because of the way in which it is not just a single person who has a need, but a whole collective and a community, that it really could, through good systems, be very helpful to getting people with especially common chronic diseases the healthcare access and often prevention that they need if we thought more strategically. Yep, targeted messaging, sort of that more personalized information flow often makes a big difference because if I get a pamphlet and it's to everybody, I'm not necessarily thinking that it's exactly to me. And if it's something that I can see myself in, I'm much more likely to follow those directions. Yeah, not only reduce the price of insulin, but reduce the coverage costs, making things actually much more affordable. If we had a much more affordable healthcare system. So I'm hoping that one of you will get the MPH and fix that. Um, any of you interested in policy, perhaps? Other nations can do it. And then this last question in this section about where have you seen healthcare organizations or public health really sort of start to make a difference? Yeah, Dearborn has been making big strides. Getting their own department of public health has really made a difference. And that local kind of knowledge makes it so much easier to reach out to people and for people to trust. So local public health is one of the places where most of the big work is done. And many people could argue that all health is local. It's affected globally and nationally and, at the state level. But really, all of our health tends to be, you know, dictated by our local environment. And So spreading awareness. Ooh, I own the strategy for our company's population health platform. Nice. I knew we had some big hitters in here. Yeah, I mean, primary care physicians are like the unsung both heroes and, so much is put on their plates. Being able to help them do their best jobs, super important. Um, oh yeah, peer health education. I mean, there's been some amazing things that have come out of looking at the power of other people in your same situation, both as support or allies, or even kind of getting yourself up out of the couch and kind of moving people to the next level. So maybe for kind of this last set of questions, we could unmute and talk to each other. Revolutionary. I've been doing an awful lot of talking. So if you think about what you saw or read, or even what you've experienced, what has surprised you about some of the strategies to tackle diabetes? And, I maybe jumped the gun at talking about the limitations of getting the medications because some of them have been implicated in weight loss. But there are other things besides that. So Reed, please just unmute as well.
So I guess for me, just in looking at this, and obviously it's in the title of the article, right? It's population health approaches to diabetes management, or whatever it's population health is in the title. But the thing that strikes me, I guess, in looking at these approaches, I have a family member with diabetes, and I'm thinking about, okay, what has that experience been like with looking at my family member who, what approaches have I seen kind of brought to them? And so many of the approaches that I feel like we have traditionally in health are very individually focused.
Mhm.
And so what I appreciate about the approaches that are in this article is that it really does provide an opportunity for us to say, no, 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 there's more at stake here than just what the individual can do and what their risk factors are. How can we take this from, well, you need to talk to a certified diabetes educator and eat better, to, well, maybe there's something in your environment that's really a struggle, or maybe you do have access issues,
Mhm.
or you don't have enough information to actually make the good choice that you need to, or there's nowhere to get the food that will
Yep.
improve your A1C. So it feels like so much of the way that we typically operate is in this individual patient, individual solution opportunity. And the population health approach, what I like is that it gives that option to think a little bit more broadly, because there's more at stake.
Anybody want to build on that? Population health approaches or community health approaches take a special kind of thinking because it goes beyond what is happening at that individual patient, doctor, patient, nurse intersection, or even patient family. A lot of worry by family members and not knowing kind of how to make it better. Um,
Can you hear me okay? Okay.
yes.
So I'm actually the one that owns that population health platform.
Yes.
And so I I thought I knew so much about diabetes and diabetes management and the testing that you need and all of that. But this is my second time having gestational diabetes. And I didn't realize how, even with my level of education on it, how hard that health literacy is and overcoming that. So even though I get to see all of this big data picture of what diabetes, who's getting their screenings and who's not and what that means, it's not always the complete picture until you get to see that sort of action or that sort of behavior aspect of it. And it's, I thought I knew everything. And clearly, even with all that knowledge, it's that behavior part that's so hard to really grasp and make a difference on.
Yeah. No, that's a great example. And it's actually the place where other people being able to be in the same boat and share, for instance, like, how did I do it? Or we had a faculty member a few years ago that started a walking program in Detroit because it really was sort of like individuals having to get themselves up and out. But if you could get a dozen people meeting regularly, it becomes a social gathering. They found all sorts of benefits, but you couldn't get people to like just go out on their own. So, Erin?
Hi, nice to meet everyone. I am the policy and peer health education person in the document.
Perfect.
I come at population health from a disability justice angle. So what really strikes me about the difference between like population health and individual, especially with chronic disease, is like everyone has a role in creating collective access, whether it's collective access to care or medications or like to information and understanding how to navigate care. And I think like one thing that's a strength of like community-based approaches is finding ways for people in the community to provide that education and like mutual aid to each other so that it isn't just like one program that may not always be there that's in charge of doing this, but everyone learns how to support each other and it becomes more sustainable.
Yeah, collective action, hugely important in today's healthcare because we are a little bit at our, I'll call it, own mercy if it's just us. Shadi?
Yeah, hello everyone. Another thing I wanted to add on is how your environment plays a role and policies on your health. So I did my capstone project on redlining and health, and from what I found, people that lived in redline neighborhoods would typically have worse health outcomes. For example, diabetes was like one of them in comparison to someone that might live in the same city but just a different region of the city.
Oh yeah, it's a great example. And we have a fair amount of knowledge about that environmental differential inside of communities. And it's pretty striking. I mean, we do not have equal access to healthy environments. So it does come into play in, I'll call it the life course of people, not just when they get, a disease like diabetes. So we're absolutely at the nexus of so many great disciplines, policy and healthcare and environmental health, just in this one example. So this is just a little bit of what it's like when we have class. And this is a population health version. There's, slightly different versions if you're looking at epidemiological sort of concepts and skills or biostatistics. But in many ways, it's this over and over again inside of each one of those classes. And, every professor has their own flavor. So, some of them are funnier than I am. Some of them are, more serious than I am. But, but each of them has worked inside of this kind of venue and really likes, I mean, most of the faculty love the online program because as working professionals, you have the ability to take what we are sort of giving out and to see how it directly relates to your jobs or to the health in your communities, much more so than our kind of residential program where the students often may have had a little bit of experience, but nothing compared to kind of the depth of your experience. And most of the faculty that are teaching in the online are, kind of keeping it to themselves because we don't necessarily share with the other faculty. But I think that you all bring, just even in this conversation, uh, a great example of what you will meet when you join an online program, hopefully ours.